formally open us. So welcome, thank you for joining us to spend some time today talking about, listening about, and we hope you'll engage with your questions in your chat on why goals of care conversations have become so important, especially during the pandemic. What has happened during the pandemic that really has elevated the need to hold these conversations with our patients. I want to thank Brandy Vinson and Quality Insights Network 5 for elevating the need for this and identifying that there was a need for this amongst the teams at dialysis centers and inviting us to present. So thank you. So I want to introduce Dr. Woody Moss, Alvin Moss, and Dr. Liz Anderson. Woody is a nephrologist and palliative care physician, an ethicist who's been working on supportive care for people with kidney failure for many years. Really has been a leader in developing the field. Dr. Anderson is a social worker who comes again from a twin background of having worked for a number of years in hospice and then having worked at Network 5, working with dialysis center teams and helping them resolve problems, identify needs of patients. And she's now working on research on the needs of how do we care for family members, especially rural family members of dialysis patients. So I'm going to turn it over, Woody, I think you're going to announce our CE, and then I'm going to turn it over to you guys to kick it off.
Sure. Yeah, and May asked me just to make this announcement. So this is so that you can get continuing education credit for attending this webinar. 1 CE credit is available to nurses and social workers who pre-registered and who attend today's event, and that includes having to fill out the evaluation at the end. So, and then you'll get your continuing education credit form approximately a month after this event. And when you exit, please be sure that you click on the continue button so that you can complete the evaluation form so that you will then be entitled to a CE credit. All right, that's the housekeeping, Dale and Liz. Liz, why don't you say hello?
You're on mute, Liz.
Sorry, it takes my computer a second to think. Hello, I am so excited to be here today and look forward to this. I think we're gonna start this presentation with Dr. Moss, and I will jump in at midpoint, and certainly together we are hoping that we can complement each other. So he's gonna help me out when we get into the medical stuff, and I'll help him out to bring in the social work perspective.
Good. So we established these objectives to explain why goals of care conversations matter to patients. And really, the last bullet is especially why they matter during the COVID-19 pandemic, and even perhaps they may continue to matter more as a result of this pandemic moving forward. We'll demonstrate how to use the ask, tell, ask approach to conduct these conversations. And then Liz is a social worker, I'm a nephrologist, advanced practice providers, nurses, social workers, actually anyone can be involved in conducting these goals of care conversation. And hopefully this will be a help to those viewing this webinar. Next slide, please. So the ask, tell, ask approach is one that allows you to figure out first where the patient and the family are with their understanding, then to provide information to fill in the gaps, and then to, with the second ask, to check their understanding, see what they're going to take away from the conversation, and even what they might tell their family and friends about what was discussed. Next slide, please. So prior to the pandemic, what the research on dialysis patients shows is that really there were not many conversations. One study suggested that nephrologists had had these conversations with less than 10% of their dialysis patients, but yet The study showed that patients wanted to have these conversations. They were waiting for their nephrologist or their nurse practitioner to initiate the subject. They didn't want to suggest that they weren't optimistic about how they were going to do. And therefore, if they brought up wanting to discuss end-of-life type issues, they were thought maybe they weren't optimistic enough and with the program enough. So, and then the other thing is that often when patients have done some advanced care planning, perhaps with an attorney as part of estate planning, those forms weren't known to the treating clinicians. And so really the system wasn't working well pre-pandemic. And of course, Liz, feel free to jump in, or Dale, feel free to jump in at any point. So where we're starting, our starting point is we were not, and I say as a nephrology community, we were not doing advanced care planning well. Next, please. And one of the things, though, that we know from looking at the literature and by not systematically having these discussions is that we were not identifying the fact that patients have diverse goals. Not every patient on dialysis wants the same type of treatment moving forward. Not every patient would want to go to the ICU and be on a breathing machine. Not every patient would want CPR. And the other thing that research has shown is that the vast majority, over 90% of nephrologists think they know what's important to their patients, but actually they don't, is at least what the research would suggest. That underscores the importance of having to ask. So this is a study that was done at Vanderbilt looking at a number of seriously ill, older chronic kidney disease patients and asking them about treatments they would and would not want in the future and what would be most important to them. And notice that roughly a little over a third said that they'd be willing to try treatments, including dialysis, but that they didn't want to suffer. A third said really moving forward, thinking into the future, they would want their treatment focused on their comfort. By the way, in that group, only 5% said they really would want to initiate dialysis. 20% said they want to live as long as possible, and 12% were not sure. So this really is a diverse set of preferences, but not ones that would be apparent without really a discussion about what's most important to the patient. So clinicians didn't know, and notice this is in this another study looking at, so this wasn't just the first study this is another study, again, looking at how much the nephrologists and nurse practitioners understand what's important to their patients with stage 4 or 5 chronic kidney disease, patients who are pre-dialysis. And notice the top bullet point, the clinicians were wrong 65% of the time as to what was the top priority for the patients with chronic kidney disease. And then if you look at the priorities, the top priority for most of them was maintaining independence. Staying alive was the top priority for 35%, reducing pain 9%, reducing other symptoms 6%. So really this is pretty clear from several studies that I've now sort of reviewed with you, that patients differ in what they want. Next slide, please. So if we start with what we know about dialysis patients' understanding of their prognosis and how their understanding of their prognosis relates to their willingness to conduct advanced care planning, there was this helpful study that's referenced at the bottom of the slide, where the vast majority of patients either were very optimistic, these are dialysis patients, they thought they would live 10 years or longer, or else they weren't sure, but none of them really thought they only had 3 to 5 years to live, which is actually the average survival for dialysis patients. And if they were optimistic, they were less likely to engage in advanced care planning. And as a result, because they didn't engage in advanced care planning, they were more likely to have had an intensive care unit admission in the last 30 days of life and more likely to have had CPR, mechanical ventilation, or a feeding tube. So that's sort of the baseline. That's what we know about how well we were doing with advanced care planning with dialysis patients prior to the COVID-19 pandemic. Now, what we've heard, and this is more informal, but because Dale and I and Liz have been involved with working with a number of dialysis centers around the country in a project to try and improve advanced care planning and shared decision-making and goals of care conversations. We've received lots of feedback from lots of different people in the dialysis community. And what and also we've heard it from other colleagues who conduct advanced care planning with seriously ill patients. And what we've heard is that there's a heightened concern about mortality, and there's really more of a receptivity to advanced care planning. And that really results in the fact that there's more of a willingness to have these goals of care conversations, including using the ask, tell, ask approach that Liz and I are going to talk to you about. Next slide, please. So really if you can go back one slide, Liz. Yeah, so doesn't want to do that slide, huh? Yeah, you go back 2 slides now. So what we really know is that clinicians need to take the lead because patients are expecting them to. Yeah, can you go back 2 slides?
I'm sorry.
Yeah.
I'm having a problem because I couldn't. Oh my gosh. Usually this thing is
it's going forward on you.
all right.
That's weird.
All right, well, so to sort of pick up even without the slide.
There you go.
Clinicians really need to take the lead, and the ask, tell, ask approach is a pretty simple approach. As I was reviewing the literature for something else, I realized that back in 2005, 15 years ago, the ask, tell, ask approach was being recommended to talking to seriously ill patients. And it's been consistently widely discussed in the treatment of seriously ill patient literature for now almost 2 decades. And yet there's not a huge knowledge of it. And we are providing to everybody who's part of this webinar ask, tell, ask cards for you and ones that you can share with your colleagues. You can even keep this little laminated 3x5 card. Dale's holding one up now. Thank you, Dale. You can keep it in your pocket, or take a picture of it on your phone and just have it to quickly refer to as you're going through the conversation. And really a large part of what we're going to do is talk about how really social workers, nephrology nurses, nephrologists can use this approach to conversations to really find out what are your particular patients' values, what is most important to them, what are their top priorities, what types of treatments would they want or not want if they were to get more seriously ill. So that's sort of, I'm trying to sort of set up and prepare you for the fact that patients have different values, that they want to, over 90% say they want to have these conversations. They're waiting for us to bring up the topic. So next slide, and I think this one turns it over to you, Liz.
Okay. Sorry about the slide debacle before. So we are going to talk for the next few minutes about this ask, tell, ask approach that Dr. Moss was talking about earlier. So we want to really start the conversation by making sure that we get a full understanding of the situation. So my own general rule of thumb is hold off on giving any advice or suggestions until you really have a clear picture from the patient what their situation is. And so that first approach, to get that information, you have to ask some questions, right? So we're going to elicit from them, what are their concerns? What are their values? So, sometimes I think we go in and we think, I need to know, do you want a DNR? Do you want mechanical ventilation? But we're really saying, let's start out broad and really figure out what your values are, going back to some of those earlier slides about, is it to live for a long time or is it to be comfortable? And let the patient choose to speak for themselves in the future. So giving them a choice right now and saying, if we can have this conversation now, then you're going to have a lot of control over your life in the future. Excuse me, the second skill being telling. So that's where we're giving information. And in the telling, I think, there's some discrepancy between what a nephrologist is going to tell a patient and what a social worker is going to tell a patient. But the important piece is that we are both communicating that it's important to document what those wishes are. Understanding that at the end of life, most people have some complications. And so helping communicate what that prognosis is, what people's options are. We'll talk more about that in a minute. And also giving them information about what interventions might be possible. So what are some of those scenarios?
Yeah.
I think
Hey, Liz, could I just make a comment about the
Sure.
first, at least, and nephrologist, but I want to, claim responsibility or assume responsibility like my colleagues, that I don't think we spend enough time with the first ask, and we don't ask open-ended questions and then listen. So I might start off by saying, after how are things going now compared to a year ago? And clearly this would be a patient that we might not be surprised if the patient died in the next year. So really we've typically seen the patient going downhill. So I might ask the patient, what's your understanding of your major medical problem now? And I might even follow up if they say, well, I know my kidney function is bad, or I know my heart is bad. I might follow up with, well, how serious is that problem, and see what they tell me. And I might even ask, what have the other physicians or people caring for you told you about your problem? And then, so that's sort of a way of figuring out where they are. And then what you were just talking about, which is excellent, is, all right, given that, now what would be most important to you in your treatment? What would you want to avoid? So I just want to underscore the fact we're really, nephrologists are really good at telling. We're not really good at asking.
I love that approach because I think also it makes the conversation less difficult, because when we're telling people about their prognosis, we can expect people to get defensive and frightened and scared. But I think what Dr. Moss is referring to is that most patients already have some kind of idea. And so that's where we're going to start. Even if people maybe don't know exactly what their diagnosis is, they're probably going to say, I know something's not right? So it gives that opening there for that. So thank you. Yes. And I think that even when we're telling people and starting to give that information, it's important for us to continue to elicit those concerns from them and exploring that with them. And then you can see after that phase is done, and we'll break this out in more detail in future slides, we come back with more questions. But in the last part, we're really coming back with, what questions do you have? And also that check-in, like, what are your takeaways from this conversation? So helping people tell us what they understand in terms of what they talk about, which we know from just a social learning approach that that's really effective in helping people move forward in whatever their plans are. So asking them how they plan to discuss it with family, etc. Okay, I'm probably not the best slide presenter. So what I want to spend a little bit of time talking about is, so we talk about these things, but how do we actually do this? And what are the skills that we need to have these conversations? And I think the most important thing for us to remember is how important it is to have presence. When we're talking to people about advanced care planning and their future life or death, that can be a really important conversation. And what I've heard from patients over and over again in my own practice and in my research is when we say, what do you want from someone who's going to have this conversation with you? They'll say things like, I want them to sit down. I want them to look at me. I want them to listen and use their ears. And so I think a lot of times we get really hung up in what we have to say, and we ignore how important it is that we hold that presence and acknowledge that this is a really big conversation to have. So all of that being said, there are a few skills that I would say we use in conjunction with the ask, tell, ask approach that are drawn from motivational interviewing. So just like Dr. Ma said, the use of open-ended questions. So being able to come in with a couple of really good open-ended questions can give us an awful lot of information. And so having some of those, and I think there's some listed on the cards that you all will get for this, is going to be an important part of that goals of care conversation. The second skill is that listening, reflection, and empathy. I often tell social work students, it is not healing to ask people questions. Asking questions is not a healing process. Yet listening and reflecting and being empathetic is a healing process. So, you're being charged with having a difficult conversation. One of the things that you can do is provide some emotional relief by offering that skill. Also, what we've learned is that when providers are really good at reflecting and listening and providing empathy, they don't have to ask questions because people feel connected and they offer. So it becomes less of an interrogation and more of a conversation. The third skill that I think is important when we talk about ask, tell, ask is when we get into that tell, that we are only going to tell information after we understand the problem. So after we've asked the questions and after we've reflected, listened, and given empathy. So information giving is very important, but it's important that we don't do it first. Another skill is this that I think, especially healthcare providers, that we're all guilty of, is what we call resist the writing reflex is what we want to do. So we are all trained healthcare providers. We all want everybody to make the right decisions that we think are best for them. And we're trained at fixing things. And so a lot of times when we hear people saying things that we know aren't possible, particularly about treatment options, we just want to correct them. And a lot of the literature and research says actually when we try to correct people, when we try to persuade people or argue with people, it actually makes them hold stronger and more fiercely to their position. So when having these conversations, our job isn't to fix, persuade, or argue. We're going to start where they are, and we're going to resist that urge to do that. And understand that some people might be resistant, and that's okay. Because actually, if we want to help move people along, again, we got to sit with that resistance with them. So what are we asking about? So now we're going to get a little bit more into those nuts and bolts. There are different models about where do you start. And I think some of that is really got to be determined by what your relationship is with the client. But one of the logical places to start, in addition to that values conversation, is asking them about their decision maker. And I think I've heard Dr. Moss talk about that this is a good lead-in, and it tends to feel less threatening than starting with what would you want in this scenario, and this scenario. So really just opening up, who would you want to make medical decisions for you if you couldn't speak for yourself? And then questions to the decision maker. What do you think about your role as a healthcare decision maker? I think in this stage, it's also really important to allow people to talk about what their concerns are. So as a social worker, a lot of times I would hear patients say, I don't know who I want to be my decision maker. I'm really worried if I make my husband my decision maker, he's not going to be able to follow through on my wishes. And so being able to also open that up to have some conversation around what that might look like. We also want to ask them about their understandings and values and concerns, as Dr. Moss talked about in the beginning. So by doing that too, I think we're really providing a person-centered approach to care. I firmly believe that we are never going to be effective at our profession, any profession, if we don't have a relationship with clients. And I think that when we start with where the client is and really value their position, we build that relationship as well, which increases trust too. So these are the questions in writing that Dr. Moss led in with. So What is your understanding of your health right now? How serious is that? How are you doing compared to a year ago? What is most important to you if you're receiving treatment if you get sicker? What do you hope for? What would you want to avoid? And you can see these are open-ended questions that don't, they can't be answered in a yes/no format. Hopefully they're going to bring us a lot of information.
And yeah, Liz, and if I can just say too, like what would you most want to avoid? It's very interesting. Patients often have very formed opinions based on their life experience. So if their aunt or their mother or father were in a nursing home after a stroke, maybe in a coma, maybe they were being kept alive with a feeding tube, and they really said, that's just not what I would want, it can help them to articulate what their values are based on their life experience. And it doesn't need to be a parent. It could be a friend, a colleague, family member, whatever. But it turns out when you start asking patients, they do often have ideas about what they want and they don't want.
Absolutely. And I think that's a really good point, especially if you're finding it a struggle to elicit that from clients, is to ask the question, I'm wondering if you have ever known anybody that's been through something like this before, and what was that like? And generally when you ask that question, you'll get the flood. And so just having a few of those questions in your back pocket is important. I say that another important piece is helping elicit what those coping and resilience strategies are as well. So again, resisting the writing reflex, we should be going in as curious helpers that we're trying to really elicit from people what their own coping skills are, rather than telling people what they are. When I do this exercise with students, especially early on in the semester, even second year MSW students, they want so bad to tell their clients what to do and to give them a list of ways to cope. But one of the things we really know from the psychological literature is that people are much more likely to engage in a coping skill if they feel like it was their own idea. And so we're going to ask people about that. And you can see in the bubble on the side, just, I'm wondering if you can tell me about a time that you have been through something really difficult. And going back to those motivational interviewing skills, pause and listen, making sure we give people time to reflect. So, okay, you took care of your mom when she was sick, and while that was difficult, you were able to make sure she was comfortable. So, weaving in that empathy as well is an important piece. And in doing that, what we know is when we can draw on the experiences of people when they've successfully resolved conflict, it helps build their self-efficacy, and it helps build their confidence about how they're going to deal with future problems. So then we're going to switch gears a little bit. Like Dr. Moss said, we're going to fill in where our client might have left off. So we might go back to something the patient raised earlier and give some more information. I think an important skill that I learned from motivational interviewing about the telling stage is really highlighted in that second bullet. We want to give information in small chunks. Actually, we talk about like chunk, check, chunk. We give them a chunk of information, check in if they understand it, give them another chunk of information. So you can see, again, we've got some language here about how we would do that. You said that you were worried that you'll get COVID-19 and that you would die. And we pause. Because again, sometimes when we just make a statement, people will respond without us asking a question. And then we can jump in, and especially if we have that medical background, and give some information about what it really is like for COVID-19. So as a social worker in this position, I might say something like, one of the things that I've learned from the nephrologist on our team, or one of the things that I've heard our physician talk about is this. And in that moment, I can tell this is really important to you, and I'm wondering if, and Dr. Moss and I will do a role play on this in a little bit, but I'm wondering if it would be okay with you if we pulled in the nephrologist together and got some information on that, right? So I think that we can help bridge that here as well. Do you want to talk a little bit, Dr. Moss, about that?
Yeah, no, so I'm just looking that we have a comment that
Okay.
difficult times and tend to be quite private. So to me, respecting a patient's level of comfort with the discussion is important. And I think the person making this comment obviously is very sensitive and attuned to this issue. And we don't want to get ahead of the patient. We certainly want to proceed at the pace at which the patient is comfortable. And so the chat comment says sometimes slowly introducing an idea so it becomes more comfortable rather than throwing too much at the patient right away is helpful to build trust. And absolutely. So I think that's a very astute comment. And I think this is where, honestly, and Liz, see if you agree, nonverbal communication sometimes can be as important, if not more important, than even what the patient is saying. Would you agree with that?
100%, absolutely. Our nonverbal communication and their nonverbal communication. And so absolutely, I think you have to use some of your professional wisdom here and taking a read on that. And I can't see the comment because I'm in presenter mode, but just to respond to that, I think that is part of it. We have to go at their pace. And that's why we really want to start where they are. Does that
Yeah, and I think so. So the question might be, so let me ask you a question. So if we don't want to proceed too quickly, what might be a way that you would slowly proceed into asking about something where maybe they've experienced a difficult time? Maybe they've already been in the hospital. Maybe they already were on a ventilator with their COVID-19, and now they're really recovering very slowly and have thoughts about whether or not they'd even want to go back to the hospital again. How would you sort of unpack what they're thinking and feeling about that?
Are you asking me that? Or the
Yes, I am.
typing? Okay.
Yes.
So yeah, I think that so my response to that would be to come in and say, I heard you were in the hospital last week and I'm, was really concerned about you. Tell me a little bit about what happened. So I would open it up I would not come in like, oh, we need to talk about death and dying. Oh, we need to get you to sign an advance directive because you were in the hospital last week. I would definitely not do that. I would open it up broadly and really listen for any language that the client but the patient would give us that would indicate what their desire is. And so if the patient says to me, it was awful, I was so painful, I missed my family so much, then that would give me a position to say, you know what, I really appreciate your honesty here. And I want to make sure that your goals are what your goals are. I want to make sure that we can meet those goals. And I'm wondering what your thoughts are about how we can do that. So I would go back to asking again, elicit if they are aware of advanced care planning. And if they're not, then I would say, I'm wondering if it'd be okay if I share with you a little bit about what other patients do in this circumstance. And then that way, if the patient was like, yeah, I was in the hospital and, that it was bad, but they did everything that they could. And I felt that there was some significant resistance there. I might say, if that were to happen again, like if you give any thought, like if that were to happen again, is there anything you would change or do differently? And even if a patient says, I actually want everything, like there was some question about whether you're going to put me on a ventilator or not, they better darn well put me on a ventilator, I would say, that's really important information for us to have. And I would go into an advanced care plan and make sure that we've documented that so that everybody knows what that is.
Right. So let me add to that if I could. And I think I completely agree with everything you've said, but I'm also reflecting back on that chat comment from before. Really to slowly introduce it, one thing that I found to be helpful is I've heard that you were in the hospital last week, and from what you've said, it sounds like it was a difficult situation for you. would it be okay if we talked about that a little bit more? So I might ask permission to, and that would be, and I hope the person who did the chat would feel that's okay. And if not, maybe make some other thoughts, but to try and get permission to explore it. And then sort of similar to your question, what was that like for you? And what additional thoughts have you had as you think about the experience you've been through? Again, I think building on what you were saying, just ways to sort of help understand better where the patient is now as a result of what they've been through.
Mm-hmm. I love that.
If I could jump in, this is Dale. One of the things we learned from the dialysis center teams in Pathways is when we first started working with them on goals of care conversations, they envisioned it as this formal meeting, and they were working on scheduling and getting everybody on the dialysis center team, you know, their nephrologist, their social worker in the room, and their family members in the room. And what they discovered was that really it was more effective if it was these small bits of conversation over time. Maybe eventually you would all sit down and have a formal meeting, but really the process of slowly exploring and relationship building was what was needed, much more so than a formal meeting. And the amazing possibility that exists in the dialysis centers, you're seeing people 3 times a week. So you can, usually 3 times, you know, you can do a little bit and let it marinate and come back. You know, we started talking about that. I want to know if you have any more thoughts about it. So that's,
yeah, and Dale, if I could just build on what you said, and what we learned is that although initially the dialysis centers thought they needed to have the nephrologist there and the nephrologist be part of the discussion, often with the nephrologist's permission, really it was the nurse practitioners and particularly even the social workers who ended up carrying these conversations forward. And it was very rewarding for the patients and for the social workers. They didn't feel overwhelmed. They felt like they were really learning helpful information to better take care of patients and respect their wishes. So really, this is a process that we're sharing with you our experience, but especially as we've gotten through COVID-19, where everybody was surprised at how patients were just that much more willing to open up with them because of what they've been seeing and thinking and feeling and experienced. Back to you, Liz.
Yeah, absolutely. And I echo those sentiments. And I think to Dale's point, when I've talked to patients over and over again about the conversations that they want to have, what I hear is, if you're going to ask me to engage in this really big conversation, I need to have relationship. And relationship doesn't happen in a snap. And so, you know, it does take time. And so building that is important. I mean, I know there are times that we have to urgently have these conversations, but I think honoring that piece is so important, as the person that chatted in said. Another tale for a different patient, other concerns. So here are some other examples where we might give some more information. So going back to a patient and said, you know, you said that you really didn't want to go back to the hospital, even if it gets hard to breathe. Again, pause, let the patient respond. And then coming back, just as we did in the last scenario, there are some options for people who don't want to go to the hospital. Is it okay if I share? So going back to Dr. Moss's point that we should be asking permission before we're giving that information. Having a hospice program, bring those medicines to you at home would help you stay out of the hospital and keep comfortable. So pause giving that information, see how they respond to that, and then checking back in. Does that sound like what you would want if you were to get sicker? So you can see little chunks of information, checking in. And I think that pause is, again, non-verbally communicating. Take your time. I'm here with you. I'm present. I'm being deliberate in wanting to hear your honest answer. And then more tells, you know, discuss the common future complications and choices. So I don't know, Dr. Moss, do you want to help me out here? Because I think we're getting into some of the, how to really go over the interventions.
Sure. Yeah. And fortunately, I'm trying to recall although the mortality was higher for dialysis patients than the general population, it wasn't, it wasn't outrageously high, thankfully. But nonetheless, it is, the mortality may have been 5% or something like that, 8% for dialysis patients. And if we're looking at the general population where it's less than 1%, then it's clearly a concern. But people are thinking about COVID-19 and whether or not they would want to be on a breathing machine, and whether or not they've ever been on a breathing machine before, and would they want it, would they not want it. And so these are topics, and again, these are on the Ask Tell Ask card. These are things that you can systematically go through. And even the statement CPR is not as successful as most people think. Everybody sees CPR on TV and assumes, well, it works for everybody. Isn't it great? When actually it works for the minority of people. Maybe, one out of 6 people survive CPR and leave the hospital. And if they have chronic kidney disease and stage kidney disease, it may even be a little worse than that. So these are things that are important to talk to patients, but I would start with the relationship and the rapport and the more general overall goals for treatment. I would not immediately get into a discussion of CPR before I've had these discussions of these other issues. So for those of you who are familiar with the POLST form or the MOLST form, the medical orders for life-sustaining treatment, physician orders for life-sustaining treatment, I always go to section B first. What level of medical intervention would the patient want? And then once I understand that, then I can back into, well, based on what you've told me, I'm assuming, make sure I have this right, that you would or you wouldn't. So those are the medical thoughts about where we go with this, okay?
And I want to do a time check to my colleagues. We're at 12:42.
Yes.
I saw that.
So
we need to move.
We need to move on if we want to have some role plays.
Okay. All right. So again, I think we've already gone over a lot of this.
Yes.
But exploring with them what situations they might want to stop dialysis. I always talk about the sometimes statement, and I think Dr. Moss might have written this one, said many people, it's the same thing. So sometimes people tell me that they would not like to keep going on dialysis. So I'm really opening that with, I'm curious where you are, acknowledging that piece. We want to make sure that we have time to really hear the patient's story and values. And I really think, especially if you are working with a person who is very unlike you, culturally or however, paying attention to story is so important in terms of building relationship and understanding. So you can see here some examples of just questions that you can ask to elicit those. And these are on the cards, correct? Am I right about that?
Yes.
So
yes, some of them are. Yes.
So just how much people are willing to go through, and what they would not be willing to live without. One of the things that we hear a lot of times is that providers are exceptionally concerned about the amount of emotion that is going to emerge from patients or loved ones. And what we now know is that actually experiencing those emotions is a really important part of working through all of that. So, and it's healing. It is healing to people when we acknowledge their emotional presence. And usually when we acknowledge their emotion, we're able to talk to them in a much more rational way. So I often remind people that when we bring up something that's difficult, people immediately kind of go fight or flight, lower brain, prefrontal cortex goes offline. I cannot be rational. I cannot make any decisions. And so we have to respond to that emotional piece to get people back up here in their forebrain, able to work on it. And plus it is, I think Dr. Moss or Dale were alluding to how important it is for relationship building and staff morale. Our staff that have engaged in this have found that very meaningful. So be on the lookout for emotion and name it and normalize it. So, it's normal to feel scared or confused. and angry, etc. That is all a normal part of really what is probably anticipatory grief. When emotion is really high, these are a few things that we can do. Is one, trying to stay calm ourselves, which speaks to how important it is that you're taking care of you, that you're taking deep breaths before you go into that meeting and maybe doing your own little mindful minute, because that calm is contagious. Actually, anxiety is super contagious. They say it's the most contagious emotion. So if we can help people be centered and calm, so that means we're communicating, I can tolerate your emotion and I'm not going to react to that negatively. We're not going to fix them. We're not going to try to say, no, don't cry, because we allow emotion. And actually, when we train social workers to be therapists, we always say that you can challenge people's thoughts, but you never ever challenge people's emotions. Their emotions are their emotions, so you let them own that. So lean into it, listen to that, give some good eye contact, and try to offer a reflection using an emotional word, using the word that you think describes that. Oh my gosh, time.
We need to.
Okay,
This is
go on.
the second ask. I'll just jump in. That was the second ask. What questions do you have now? What are you going to tell your family about what we discussed? I think it's going to be valuable for us to get to the role play. So
okay, let's go to the role play, and you all will have access to the slides. So we are going to role play a scenario, and we're going to start with me as a social worker, and Dale is our client. And Dale, I see you're on mute. You going to be able to? Okay. And Dale is going to be the caregiver of a patient. So that just a background, that the patient is Robert. He's been on dialysis for 3 years, but in the last 3 months, he's had a lot of decline. And he's been combative during treatment and tries to pull out his lines. He's in emotional distress. And we believe that we need to talk to Ruth. And I'm here to start that conversation today. But I heard from some other people that Ruth might really want treatment at all costs. So we're going to role play that. So good morning, Ruth. Thank you so much for coming in today.
Good morning. Good morning.
So I've been really I've had you on my mind so much. You've had so much going on with your dad, and really just wanted to check in with you. I felt concerned and see how things are going from your end. What's been going on?
Well, you're right. It's been difficult the last couple months. He's a fighter, and this is a hard time for all of us.
Mm-hmm.
Especially, it's been hard that I can't be with him as much.
Mm-hmm. So yeah, he's been fighting for a long time, and you've witnessed that, and now here you are in this position, and you can't spend as much time with him.
Yeah, so I'm kind of worried about him too.
Mm-hmm. So talk to me a little bit about what you're worried about, and yeah, fill me in.
Well, I think, one of the things I'm worried about is that you guys are going to say it's time to give up on him. Mm-hmm. And in fact, I thought that's probably what you wanted to do today, is just say, give up. And he's a fighter, and that's how he's gotten where he is.
Mm-hmm. Sounds like you love your dad an awful lot, and you want to make sure that he is protected, and you are really concerned that the healthcare team might not want to do that.
Yeah, and I've been hearing, if he were to have to go to the hospital, there wouldn't be enough dialysis machines. And I've just been hearing all these things about how, and I look at him, and he's an older guy, and I just think, is he going to be sacrificed?
Mm-hmm. So you've been hearing in the news about shortages and whether or not that is going to be a reality. Is he going to have access to all the treatment that he needs if that were to happen?
Right.
Can you talk to me a little bit about like what you know about how he's doing physically and emotionally? Like, what is your understanding of what all is going on and what the chances of that happening is?
Well, we have an uncle who's had COVID. I mean, I'm just really worried that he's going to get COVID. You know, there was somebody else at the dialysis center who got it. I mean, I'm just very worried about that for him. He's, I don't know, it seems like it's a hard period for him. It seems difficult. He comes back from dialysis. You know, I can't go there to be with him anymore. I used to go and bring lunch, and I can't be with him. And the staff has said he gets all upset and angry. And I know when he comes home, he's just exhausted, and he just doesn't want to. He used to play with my kids. He's just exhausted all the time.
Mm-hmm. So it sounds like you got a couple of different things that are worrying you right now. You know, we've got your dad. It sounds like you're hearing from the medical team that he's a little bit different in dialysis, and maybe he's not feeling quite as good as when he gets home. But at the same time, he's a fighter. And so you've got the conflict between those two things. And you're also aware that there's this pandemic happening, and you're concerned about what that really means for your dad, given those factors.
That is, yes. Yes. Yes.
Has he ever talked to you about what he would maybe want in a situation like that? If he did have to go to the hospital, do you have some idea what that would look like?
Well, the main thing he said, we haven't talked about it a lot. You know, he's not a big talker, you know, but so I may mostly take it from his life. He's a fighter. He has had to fight to get where he is. He's had to fight for everything he gave to us as kids. But I do know that when his mom was sick, that he said, I don't want that to happen to me. Mm-hmm. And he did say that, I don't want that to happen to me. And she was on machines in the hospital for like, I don't know, months. I was a little kid, but I know he said, I don't want to go like that.
Mm-hmm. So again, you're kind of in this place where it sounds like you're just uncertain what to do, because he's had this really fighting spirit his whole life that you've modeled. But things seem to be changing, and when you reflect on your family, it does seem like there might be some situations in which he doesn't want to keep going. Well,
he wants to keep going. He wants to keep going, but he doesn't want. He just says, I don't want to end up. Like, he wants to keep going, but he doesn't want to end up there.
There are certain situations that he doesn't want to be in, that he's experienced.
I think so. I think so, but I don't think he wants to talk about it.
Yeah. So you're feeling like he's pretty reserved about his conversation around.
Yeah.
So what I would suggest, what I'm wondering is that, you know, it might be helpful for us to pull in some medical expertise here. You know, it sounds to me like you might need some more information to help you make your decisions. We here want to provide your dad with the treatment that most closely aligns with who he is. And right now, you're a good source of information for us to learn that. So I'm wondering what you would think about us pulling in your dad's doctor together and having a conversation.
I would really like that. I mean, they always seem so busy. If we could get like 10 minutes to talk, I think it'd be great.
Yes. So I'm going to pause here because we have 6 minutes left. And I would just say that at this point, what we would want to do is I would go to Dr. Moss and I would say, hey, I've talked to Ruth about this situation, and here's what she's told me. And I'm wondering if you can talk to her. And so let's take that. We're going to let Dr. Moss now jump in and sort of take over that conversation.
And we're going to, for the sake of time and discussion, we're going to say that Liz and I had a separate offline conversation, and that she filled me in on the nature of her conversation with Ruth, the daughter Ruth. And so I will go in and say, so let's all get together. So now we're having a three-way meeting. And hi, I'm Dr. Moss, and Liz has put me in on your conversation. And she really told me a lot of good things about your dad, that he's been one who's been very determined in his lifetime, and he's risen to various difficult situations and done better than you might have thought he would do. So I'm interested in knowing where you think he is now, health-wise.
Well, I like that you said that, because every time somebody said, well, you only have a 10% chance of this helping or that helping, he's always come through. He has this heart problem, he'll go in the hospital, and he comes back. He always manages to come through it. And so who am I to say this time we shouldn't try everything? I just think that's not fair to not give him a chance, especially with COVID, which just shouldn't be happening. I think he needs that chance.
Right. And the reason why we're not actually talking to your dad right now is my understanding is that he has, I think, some early dementia. Is that right? Early to moderate dementia, and gets confused.
Yeah, he's pretty confused. Yeah.
Okay. All right. So really you are his decision maker, and we're having this conversation so that we can respect his wishes as related to us by you. You're speaking for him. Is that okay?
Yes, I want to protect him.
Okay. So in protecting him, if he were of sound mind and able to be in the room right now with the three of us, what things would he say he would then? Are there things he would say he wouldn't want?
He just isn't a real big talker about this, but I was telling Liz, I do remember that he said he didn't want, at the end of life, he didn't want it to be like his mom. He didn't want to be on machines. Of course, he's on a dialysis machine, but he did say he didn't want to be, I think what he meant was, here's what I think he meant. I think he wants to be with us. He wants to be with his family. I think that's what he meant when he said, I don't want it to be like her. Okay.
Let me tell you how I process that from a physician perspective. He wants to live as long and as well as possible, but die gently. What do you think about that?
Yeah, I think that's what he would say, but he wants to make sure, and I want to make sure, nobody gives up on him too soon.
Sure. So what would giving up on him too soon look like?
Well, I think if we stop dialysis right now, he's not ready.
Okay.
He needs that to live.
Yeah. So I'm sorry to interrupt, but we're getting time checks. So let me tell you where I think we are. I think I'm prepared to have a discussion with Ruth, with the daughter Ruth, about the fact that he may be willing to go back to the hospital. In fact, I'm pretty sure he would be. He may even be willing to go back on a ventilator, but it would be short term. It would be what we call a time-limited trial. And probably if after a week he's not getting better, based on his experience with his mother, he probably wouldn't want to be on the ventilator indefinitely, probably would not want a tracheostomy or a feeding tube. Quality to him would be that he would want to be able to return to Ruth and to her family and spend time at home, not time in a hospital or in a long-term acute care hospital or in a skilled nursing facility. Right, Ruth? Isn't that just...
That you got it. That's a good plan.
All right. So just to tie this together, so what you could do would be a MOLST form or POST form, depending upon the state where you practice. You could complete one of these forms that would say he either would want limited additional interventions, or perhaps he would want full treatment, but then under additional orders, you might say would only want to be on the ventilator for a week, and if not getting better, would not want to stay on the ventilator. And so these are the types of things. Thanks for bringing this slide up. Why don't you move to the next slide? But this is where we need to document what it is the patient would want, because our healthcare system needs orders. It can't just go with an advanced directive. And here are some resources. Next slide. And so notes in the medical record are very important. One of the things that we've learned from this research project we've just done is they need to be accessible. When we first started with dialysis centers a year and a half ago, there were not notes, they were not accessible, and nobody really knew what the patient wanted. We know much more about Ruth's father now because of this conversation we had, and it's really important that we document it. Next slide, please. And so this is the suggested template. We'll skip over that. Next slide. This is to let you know that there are barriers. We've learned that dialysis social workers have been very good at having these conversations, either before dialysis, after dialysis, over the phone, really in a private corner in the dialysis center. So they figured out ways to do it, even though we have the COVID-19 precaution barriers. Next slide. And we have resources. That's what the next slide shows. And these are some workarounds, telehealth being that one. And so again, more resources, and the next slide shows resources. And I don't know if, and this is just a summary of what we've been telling you about how the Ask, Tell, Ask approach allows you to practice shared decision-making, which is felt to be the ideal model for making these decisions with patients and families. Next slide. And lots of resources for you that you can read a whole lot more about this. And by the way, you can go to our website and email us, and or email Brandy and Network 5, ESRD Network 5, and we are happy to answer your questions, to try and support you in any way you can, because really our goal is that you will become more comfortable having these conversations with your patients and with their families and their legal decision makers. Other final thoughts? I think we're a minute or two over at this point.
We did get a question about whether or not a social worker could do a pulse form, and that is a physician order.
Yes, it is a physician order, but the real world truth is the social workers complete the forms and they hand them to the physician or the nurse practitioner for signature. So honestly, our social workers are very comfortable with pulse forms, and they work hand in glove with the clinicians to complete them.
Mm-hmm.
So again, please do fill out the evaluation, whether or not you want CEs. It's really helpful to get your feedback as to whether this helped you. Chat us in. Well, we could stay on for a minute or two if you want to chat. And do we need to read the CEU statement again?
No, I think we just needed to remind them that they need to click on the continue button to complete the evaluation form, and to receive the CE credit, they need to have completed the evaluation form.
And we have in the chat, can the NP sign the form? I believe that's state specific.
Yes, but the vast majority of states now that have pulse forms, the NP can sign the form. There are only a couple of states where the NP can't sign the form. In fact, get the form and see if it says NP is one of the persons who can sign it.
Right. So thank you, everyone, and thank you again to Network 5.
Where will they find the evaluation?
The evaluation form, when we end, there's
a continue button.
Continue button. So you click the continue button. So thank you so much, and thank you, my colleagues. Always fun to be your patient.
Always fun to have you.
I enjoy being cared for by your team. So thank you, everyone.
Right. Bye-bye.
Bye-bye.